Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Today we are going to record an episode on treatment beyond PD-1 progression. That's probably the wrong way to say it because we have an episode called Treatment Beyond Progression. It's the clinical trial data of what to do post PD-1 exposure. So PD-1 progressing patients, there's a retrospective study from Australia, global really, but lead authorship is from Australia. There's a prospective single-arm study, and then there's the prospective randomized phase 2 trial, what to do post PD-1 progression. So let's do that. I guess a quickfire comes first. And I had sort of teased you about this last week, but maybe we can just start. The mountains have just opened here. The ski resorts are open. There's a little bit of powder at the base now. James, I know you're a skier. Have you ever had a on-mountain rescue or emergency?
Not of myself. No, I can't remember that I've been rescued myself. Have I been? Yeah, but nothing bad. I mean, I think just kind of orthopedic type stuff, if you see what I mean. I've been with people who've had, various orthopedic issues. But nothing worse than that. So should I ask you now about your most recent rescue or not?
Yeah, sadly, I just had my first mountain rescue of myself last week, but it's a small. I just was snowboarding and few trails were open, and I ended up just on one of the flat parts, just boarding around a flat. And you got to keep your momentum. And I just got a little too close to the edge and slid over the edge. And it was just basically a slope down into the trees. And I managed to stop myself before I got too far. So I went right over the edge, dug my board in, and then had to hold onto a pole. And then 3 men had to lift me out of the snowbank. So it was, it's gotten my heart rate going. So that's it. Nothing orthopedic, touch wood.
Indeed. Yeah. Okay, so let's get into it, shall we? Yeah. I guess, a couple of general comments first, I suppose, is that if we're talking about progression post anti-PD-1, in principle, there's going to be a few issues about what was the timing of the anti-PD-1. Is it on treatment? Is there an interval? Was there adjuvant? And I guess the other thing to say is in this situation, I always, if I can, think, is there someone where you could just do some loco-regional treatment depending on the progression pattern, because sometimes that's relevant, surgery, radiotherapy maybe. And then the other thing, I think the other kind of border issue here is BRAF mutational status as well, because it might be if you've got someone with BRAF mutant melanoma who's progressed post anti-PD-1, you're going to want to go for targeted therapy. So we'll just slightly park that maybe, because I think the crux of the discussion in this situation is going to be, would you want to go with IPI on its own, or would you want to use IPI plus anti-PD-1, usually IPI-NIVO? So it's a pretty important question in clinic. So in terms of evidence, I think the first relevant publication here was Pires da Silva, Lancet Oncology, 2021. Georgina Long's the senior author of this. And this was a retrospective multi-institution cohort study, 15 centres, Australia, Europe and the US, with about 350 patients basically. And then the crux of this really is that they were resistant to anti-PD-1 or PD-L1. There's some people that have atezolizumab, says that in the abstract. And then in that situation, they either got IPI or they got IPI plus anti-PD-1, basically IPI-NIVO. So big question here is, which is better? Go on.
Yeah, they just basically collected data. They sent around a spreadsheet, one of their kind of famous Australian spreadsheets and said, look, did you have these patients who took PD-1 monotherapy? Important that it was essentially monotherapy they're looking at in the adjuvant or metastatic setting, had progression. We'll have a separate episode on the definitions, the sort of SITC definitions of PD-1 progression, primary, secondary resistance, maybe is the better word. And so this was recurrence or progression after PD-1 monotherapy. And if you had prior IPI, they excluded them because this was really a study of IPI, switch to IPI, or add IPI to a PD-1 backbone. And they just collected, what did you do with these patients? In the real world, what did you do? And, 15 centers across Australia, Europe, and the US, they collected data on 355 patients. Really, really impressive. It looks like a majority of these patients had received pembro monotherapy as their prior. I'm looking at supplementary table S1. And then that's about 2/3, a third of patients had received Nivo monotherapy. And then, it was kind of split almost 50-50 on the 355 patients going on to IPI mono versus IPI in combo. And maybe we just cut to the chase, James, if you have it in front of you, the response rate to IPI mono versus IPI combo.
Yeah. So I was just smiling then because you said that you looked at the supplementary.
Yeah.
So basically, IPI plus anti-PD-1, 31% response rate. IPI mono, 13.13% response rate. So, comments there from me. That IPI mono response rate, I think that's in the ballpark that I've anticipated and probably predicted. And actually, honestly, I think even the combo response rate there is possibly in the ballpark that one might have hoped for, at least, or expected. Obviously, it's nowhere near what you'd see in a treatment-naive population as expected. But for me, given all the caveats with the study, that looks like a real difference that I would say. Go on.
I agree. And I think that so this was the first study that put it in our heads. Can you get a response to IPI after PD-1? You can, but it's in that low-ish teens rate. Can you get a response to combo after seeing PD-1? Is the PD-1 continuation adding anything? And the answer is yes. And in fact, it's giving us a response rate in that near 30% or around 30% range. So I think that's all reasonable. If I wanted to address your question about BRAF status, I would refer people to the supplemental data of this Lancet paper. It's, I think it's table it's figure S1. It's OS by BRAF status, but it's small number. It's not that small numbers, I guess I should say, but it's only about 100 patients. That's not that small, to be clear. It's 100 patients who BRAF wild type and maybe 200 or so that were 100 patients that are BRAF mutated, 200 that are BRAF wild type. Hard to say that the curves are actually looking that much different here. They cross, each of these groups cross at least once on the graph. So I don't know what to make about BRAF status. There is a p-value associated with it in their figure S1, but I'm curious because as I say, these curves cross, so I wouldn't say much there. But this study then really kind of opened the door. In the US, there was the study by Olson et al. Dan Olson, published in JCO in 2021 as well. And this was a prospective study. So this took patients who'd progressed on PD-1 therapy as their immediate prior therapy. They could have gotten it in combinations. It didn't have to be monotherapy, but the combination could not have been with CTLA-4. And these patients got pembro plus low-dose IPI. So pembro low-dose IPI, single-arm study, prospective, not randomized. But what did you think of the study, James? What are your takeaways?
Yeah, so I think it's further support, really, for the idea that putting anti-PD-1 together with anti-CTLA-4 in the refractory setting has got more efficacy, likely more efficacy at least, shall we say, than IPI monotherapy. I guess that's my main take home. There's always with IPI going to be some issues about dose of IPI, which we've talked about elsewhere. the response rate, just to get the numbers here, was 29%. So, of course, the interesting thing there is it's kind of almost exactly concordant with a completely different data source, i.e. the Pires da Silva data set. So, again, I think maybe setting the scene for a randomized study. I mean, gone.
Well, and just in the interest of time, that study did end up happening at the same time we were developing a study through SWOG called S1616. I've told you about naming, the naming convention in SWOG. So 2016, obviously, when this study got its first triage approval in SWOG, which means it was probably being developed and discussed the year prior. So around the same time as these studies, I was trying to look at the dates in the Olson study, but I can't seem to find it. We could maybe fact check that for later. But the S1616 study was a randomized phase 2 trial. So now we go from retrospective data to prospective single arm to now a randomized phase 2. It was randomized phase 2 of Ipi-Nivo versus Ipi post PD-1 progression. Now, these are patients who were primary refractory, so who had never gotten a response to PD-1 in the prior setting. And it was looking at progression-free survival as a primary endpoint. And this study, at the behest of CTEP, really required randomization in a 3-to-1 fashion. I mean, Tony Rebus discussed the origin story for this trial a bit on that episode that we did with him, where he said, the question was really just about adding CTLA-4, but it was CTEP who said you'd have to randomize it. You'd have to do a CTLA-4 alone arm. And so then we ended up with this 3-to-1 randomization. Maybe on another episode, we can talk about what these randomization imbalances actually do to the psychology of a trial. What does it mean when you're getting randomized to the arm that was only 25% chance of being randomized to? What does that mean as a patient or as a provider when you're designing a study like that? Are you building in some bias, or are you saying we have plenty of data on CTLA-4 mono, therefore we didn't need more in this setting? But this study was, that's not necessarily what we're saying here, but the study was only right around 100 patients, less than 100 patients, randomized 3-to-1. And it was the standard dose of Ipi, if I'm not mistaken, but we could also fact check that just in case at the end, maybe we needed to add some of the flip dose Ipi, but my recollection is that it was the standard dose Ipi. And I don't know, James, you've looked at this PFS table 1, figure 1 probably a few times. What do you think of these results?
I don't know. I mean, I know the primary endpoint was PFS, but I mean, I suppose I'm always in this situation a little bit more taken with response rate, I have to say, which slightly presupposes that your responses are going to be as durable as we expect. So I think that's quite an important point in terms of follow-up. And I think it's, as we've discussed a lot, I think what's going to drive survival benefit is response durability. So just to sort of put that out there, I think this trial confirms the superiority of anti-CTLA-4 plus anti-PD-1 in this setting. But I was going to just pick up a few really excellent things that you said then as well. I mean, I love that randomization imbalance thing. I mean, is that even a thing? Is that like a known term? It would be really, really. I hadn't even. No. But I hadn't even thought about that. What are the consequences of randomization imbalance in terms of bias and what it means for patients? I think that's a great idea to talk about separately. Second thing that I was going to say, I'm impressed. Really impressed by how many times you've already mentioned supplementary data in like 10 or 15 minutes. It's like must be at least 4 times, maybe 5. So like massive kudos there. And then what was the third thing? Oh yes, no. So the third thing I was just going to do an intra podcast fact check, which was about the recruitment of the Olson study, I think, December 16 to November 19, 70 patients. So I can just kind of knock that off there. So, I mean, we could probably spend more time talking about the SWOG study, but for me, it kind of, I think, fairly definitively answered the question. What did you think?
Yeah, I mean, just to detail the results, the response rate was 28% in the combination group and 9% in the IPI alone group, but that was not the primary endpoint, as you noted. The primary endpoint was PFS. So we don't, the paper says how we don't have a p-value associated with that response. That basically just upholds those previous data sets, that it's about a low double digit or high single digit response rate to IPI alone after PD-1 progression, and right close to 30% for combination. The PFS was statistically significantly different, with a hazard ratio of 0.63, a p-value of 0.036. I won't read off the median PFS numbers here because, again, that's, as you say, that's maybe not what you're looking for in this patient population. But just to say, on that curve, if you took combination, you had about a 37% improvement in your PFS than if you took IPI alone. So I think this tells us there is value to keeping the PD-1 going post PD-1 regression, but it leaves us still open to many things. What do you do about acquired resistance? What do you do if this is coming off of the adjuvant setting versus resistance in the metastatic setting, which the study wasn't large enough to answer? And then I think maybe in the fact check, we can go back and look at the BRAF status in all of these groups and just see how this combination did, or even maybe IPI alone in the BRAF positive versus negative group.
Sounds good. All right, that's everything, I think.
Okay, good. So post PD-1 progression, I think our takeaway is combination. If you haven't seen the combination, it's reasonable to try it in the post PD-1 setting, but the responses and durability may certainly not be as good as they are in the frontline setting.
Yeah.
And
great, thank you.
To be clear, this is PD-1 CTLA-4. We don't necessarily have a robust data set on PD-1 LAG-3 post PD-1 progression. We have relativity 020, but that was a small study, so.
Yeah, all agreed.
All right.
Thank you.
Cheers, thanks.
Hi, this is a fact check for episode 62, which Sapna's going to do, which is some stuff about IPI dosing and infusion time. Sapna.
Yeah, we chatted in this episode of S1616, did the study. This is primary PD-1 refractory patients randomized 3-to-1 to IPI or IPI plus nivo. And I just questioned whether it was full dose IPI nivo exclusively or if they allowed for the inverted dose of IPI nivo. And in looking at this publication, this is the Van der Waal Nature Medicine publication, it's full dose IPI nivo. So it's 3 milligrams per kilogram of IPI and 1 milligram per kilogram of nivo. And then I just noted as I was reading this method section, something I was asking you about, which is about IPI infusion times. So the original approval of IPI was infusing over 90 minutes, whether as monotherapy or part of induction IPI nivo. And then at some point, and I don't know when, fact check within a fact check, the label changed the infusion from 90 minutes to 30 minutes. And so while this paper obviously talks about IPI for 90 minutes, that's just a historical artifact of when we designed the study, but now IPI's infused over 30 minutes. And it makes a massive difference when you're requesting slots, at least in the US, because now you don't have to have 30 for nivo, 90 plus IPI, 90 for IPI, the flush period, you don't need a 3-hour slot now. You can just practically get by with a 2-hour slot. So anyway, just a side note.
Yeah, important stuff. Same for us.
Okay.
Everywhere. Okay, thank you.
Yeah.